if you're not hypovolemic, is pretty CV cardiovascular stable. Any questions on this drug? I'm not going to go into the whole postsynaptic GABA limbic reticular activating system. Y'all don't care to know about all that. Any questions on Versed, its use in RSI? All right. Fentanyl. This is a wonderful drug. Morphine is your gold standard that everything is essentially compared to. Fentanyl's use, though, fentanyl has a shorter half-life, more of a rapid onset. Milligram for milligram, it's significantly more potent than morphine. It doesn't have the histamine release that morphine has. Morphine is notorious for histamine release, which histamine release can cause a significant decrease in your systemic vascular resistance and your blood pressure. This is a synthetic compound, phenylpiperidine derivative. So this is not a naturally occurring opioid like most of the opioids. This drug, it says it has a mean onset of 6.8 minutes, but you're usually going to see effect of this drug within 2 to 3 minutes. So it's not nearly as rapid as Versed because it's not nearly as lipid soluble. It is extensively metabolized by your liver, but it's also extensively took up by your lungs. So if you give a lot of this for a long period of time to individuals, it will be leaking out of their lungs for a long time to come. It is secreted a little bit in the urine unchanged, but it can, in large doses, cause significant bradycardia. Nothing like one of the opioids, Sufenta. You give large doses of it, and it will drop your heart rate to 30. This, you're normally going to see a floor effect of 50 to 60, but you give 5 cc's of fentanyl, and you're going to drop your heart rate. But is that a good thing before you go cramming cold steel down somebody's throat? That's good. You want to block the sympathomimetic response of your tubing grandma who has 3 coronary blockages. You don't want to stress her heart when you tube her. You might cause her to have a heart attack. So we commonly load people up with fentanyl, especially if they have coronary artery disease, before we tube them, because it'll suppress that response and keep them from getting ischemic. However, if you give them too much, you get chest wall rigidity, and then they become difficult to intubate until your paralysis from your paralytic sets in. So it all becomes a game, a balancing act. But here we go. The pre-treatment to blunt the intubation response. It has very stable hemodynamics when used alone. It does not suppress the sympathetic response, only the baroreceptor reflex. Baroreceptor being your heart rate response. So you can still get the blood pressure rise, which that's okay because you want to preserve your SVR. You want to preserve your coronary perfusion. You just don't want the tachycardia. Who knows when your coronaries are perfused? When does your heart feed itself? Does anybody know in which portion of your cardiac cycle that occurs? During diastole. Exactly. So if you have tachycardia, do you have a shortened diastole? Yeah. So as your heart rate goes up, your heart has less time to feed itself. So if you've already got a narrowing of your coronaries, you're already getting less blood and less oxygen to your heart muscle. So you don't want to get even less blood to that heart muscle, or you'll definitely get some coronary ischemia, some myocardial ischemia. You want to keep that heart rate low. Some people say that that's even more important than the actual coronary perfusion pressures. That's why you're seeing all these people on metoprolol and all these beta blockers, because the thinking now is keep grandma's heart rate down. Not necessarily keep her blood pressure sky high to keep her coronary perfusion pressure up. It's keep her heart rate down so her coronaries have plenty of time to perfuse. Where do her coronaries take off? Where do they get their blood from? They get their blood from the aortic root, which is right on the other side of your aortic valve. So if somebody, and this is in your RSI protocol somewhere, it's pretty common sense. If somebody has a significant history of aortic stenosis, severe aortic stenosis, so they don't have a competent aortic valve, and you go taking their blood pressure away from them, do you think they're at high risk for coronary ischemia? They're already compromised to begin with, so they're not going to generate aortic root pressure, so they're not going to generate pressure inside their coronaries, so they're not going to feed their myocardium, so you're going to kill them. That sounded dramatic, didn't it? When I was doing my residency, we had a 26-year-old die while she was delivering because she had undiagnosed aortic stenosis. We gave her a spinal. We dropped her afterload because you give somebody a spinal, they dilate all their vessels from here down. So she didn't have any SVR. We dropped her pressure. She didn't have an aortic root pressure. Her coronaries got ischemic and she coded. And that one lesson right there taught me the importance of coronary perfusion and the aortic stenosis. And it's actually somewhere in your Davidson County stuff, it talks about aortic stenosis and the risk of that. It actually talks about, it talks about the risk of that when you're doing RSI, that if you have a patient who has a significant history of moderate to severe aortic stenosis, you need to be cognizant of that and try to maintain their blood pressure during the RSI sequence. So I was very impressed with whoever developed your protocols because I was like, you know, they're onto this. They know what's going on. So your administration's doing a good job. Other things with the fentanyl, you can have secondary peaks like we talked about when it's washing out of the lungs. So they seem to be coming back too, and then they kind of get resedated. That's the fentanyl coming back out of their lungs. And like I said, the fentanyl is usually, it says it's got a T-half-life of 2 to 4 hours, but it's very dose dependent. So the more you give, the longer it's going to work. You give them 2 mics, it's going to be gone in 30 to 40 minutes because it's got such a large volume of distribution. 4 liters per kilogram here. It's going to go all over their body and distribute. But if you give them more, it's going to distribute and all the fluid compartments are going to get full and it's going to work a lot longer. Is this a good drug to be given to head injury patients? Is any narcotic a good drug to be given to head injury patients? No. All narcotics essentially diminish your body's CO2 drive for breathing. So you can make them hypercarbic, and y'all know what that does to your intercerebral pressure. We all make that correlation. So watch your narcotics when you're doing your RSIs with your head injury patients. I'd probably go light. You may have a transient increase in your intracranial pressure when you're RSIing your head injury patients, but that transient increase is probably okay as long as you maintain their breathing. Because do you want to mess with their intracranial pressure, or do you want to manage their intracranial pressure for the 30 seconds you tube them? So, I mean, if you trust yourself to maintain their CO2 between 35 and 45, give them 3 to 5 cc's of fentanyl if you trust yourself to do that. But if you don't trust yourself, then don't mess with the body's normal physiological process and let their body maintain their CO2 about where it's going to be. Does that make sense? Any questions on fentanyl? Yeah, no, it's got one of the shorter half-lives, and it's not as lipid soluble, and it doesn't have what they call conjugates as a bunch of the other opioids. Some of the other opioids can cause seizures, because the byproducts of its metabolism like pyridine, Demerol, and stuff, actually have seizure-producing byproducts. And then some of your other opioids are so lipid soluble that once you turn that drip off, or once you pulled that patch off, it would stay in them for days or weeks. Fentanyl, on the other hand, gets out of them quick because it's so readily metabolized in the liver. Even with people with hepatic dysfunction, it's still metabolized. So that's why it's the drug of choice for pain management. Long-term and short-term. I can't answer that. I mean, yeah, at our pain clinic, we don't do the methadone. We still do the fentanyl. The methadone, I know, is supposed to be less addictive than the fentanyl because it's a synthetic, or it doesn't. It hits more on your, like your kappa. You've got 4 different opioid or 5 different opioid receptors. There's not just one. You've got like a mu1, a mu2, a alpha, a kappa, and a sigma. And like the mu1 and mu2 are highly addictive, and the methadone, the bupremex, and some of the other ones don't hit the really highly addictive ones, and they're starting to use those more. But they have other side effects to them. Whereas the traditional opioids, yes, they're addictive, but they don't have all these other nasty side effects. So that's big money research right now in all these new designer opioids. Any other questions? All right, moving along. Morphine, to which everything is compared to. Everybody knows about morphine. It makes people happy, just like the other narcotics. You guys carry this stuff. It greets cardiac patients. It's good for pain and relaxation and addiction and all kinds of good stuff. Here we're talking about these receptors. There's the mu1, mu2 agonist. It not only has spinal analgesia, but it has supraspinal analgesia. It works on other pathways. Most of your opioid receptors are in your spinal pathways, but morphine works on some of your peripheral pathways. So that's why it's always been classified as something that everything else is compared to. It's good for moderate to severe pain. It's also good for acute LV failure and pulmonary edema. Like we talked about earlier, morphine notoriously, when you give it too fast, has histamine release. A lot of people will say, I'm allergic to morphine. You're not allergic to it. I just gave it to you too fast. That's why it turned your arm red. That's why it made you itch. That's why it dropped your blood pressure. If you just give it slow, most people have no problems with it at all. Onset is pretty quick. Well, not compared to fentanyl, but 5 to 10 minutes. It doesn't work all that long. People think it'll last a long time, but it really doesn't. It's not very soluble. It's not a very lipid soluble drug. Definitely contraindicated in pregnant women. It's one of the worst ones for the fetal ion trapping. It does cause the orthostatic hypotension in healthy subjects, bradycardia, peripheral vasodilation. A lot of that, though, is the histamine release. Nausea, vomiting is commonly reported. We do use this drug a lot in pediatrics, though. I like this, though. Level of consciousness is best indicator of ventilatory depression. And this is so true because you can give somebody 30 milligrams of morphine and they're sitting there talking to you, breathing like a champ. And then they lay there and go to sleep and they're breathing 3 times a minute. And then you wake them up and then they're breathing normal. And then they go back to sleep and they're breathing 3 times a minute. And people get worried about this, but in normal healthy people, if you're laying there sleeping, breathing 3 times a minute, yeah, your CO2 might be 60 or 70. I know that's scary, right? But you're not consuming a lot of oxygen laying there sleeping. So you're normally okay. But I mean, in the OR, we let people sit there and not breathe for 10 minutes. Seriously. To get you back breathing. I'll give you a breath after 10 minutes and see your CO2 is like 110. And I'll be like, damn it. I got to give you a little bit of Narcan. So, because I gave you too much. So, I'll give you a little bit of Narcan, and then you'll take 2 breaths, and then I'll be like, okay, this is cool. Now I don't look so stupid. So, then you'll start breathing a little bit, and you'll get your CO2 down to 90, then 80, then I'll call your name and you'll open your eyes. So, the whole goal, though, is for me not to have to do that. Morphine is commonly used in epidurals. Because of its spinal properties, it is a good epidural analgesia. It does cause a lot of urinary hesitancy, though. So in large doses, it can cause a lot of problems with people leaving the hospital because they can't pee. What else can I tell you guys about morphine? It's really good for the air hunger. When people are, it really, really depresses people's ventilatory drive. So if they're really feeling like they're not getting air, 5 milligrams of morphine and they'll settle right down. But they'll probably also not breathe when you want them to. So be careful with large doses of this. I would preference small doses of fentanyl over large doses of morphine for people who are air hungry. Because this is going to hang around for a while. Small doses of fentanyl won't. If you're just on a quick transport or you're trying to get somebody calmed down who's air hungry, a small dose of fentanyl will get you through it. This will get you in trouble and keep you in trouble. Even though this will be a little bit smoother and not quite as profound as the fentanyl will go away quicker. The morphine won't. Does that make sense? Any questions? Etomidate. It's a nasty drug. Dirty drug. I don't like it. But it's what people use in the field because it is a very cardiovascular stable drug. It doesn't make a lot of people code and whatnot. It is very well known for preserving your blood pressure, whereas most of your anesthetizing or induction drugs drop your SVR, drop your cardiac output, drop everything. I mean, you can really mess people up with a lot of these drugs. Propofol, pentothal, sodium thiopental. But this drug preserves it all. It's good for trauma patients, the RSI patients. However, if your patient is volume depleted or has bled out, even Etomidate will drop your blood pressure. So still be cognizant of that. And the other thing with this drug is when you dose somebody with this drug, especially grandma with COPD, it's going to blunt her, what's it called, her HP, hypopituitary steroid access. I don't remember exactly what it's called. But it's going to mess her natural steroid production up in her body. Adrenal cortical suppression. It's going to mess that up for several weeks. So she may need steroid replacement therapy. And that's actually a pretty big consideration for these lung patients. Her adrenal steroid production. That's, which life over limb, if you got to intubate grandma, we can give her some prednisone for several weeks. But they've always emphasized that because if people don't know about that, they discharge her from the hospital and then she runs into blood pressure issues. She's standing up and falling down because she can't maintain a blood pressure because she doesn't have enough cortisol in her body. However, it is a potent cerebral vasoconstrictor. It does, to a ceiling effect, decrease cerebral metabolic oxygen consumption, but it does maintain cerebral perfusion pressure. So that's a good thing. And it does it in a similar fashion to sodium thiopental, which is pretty impressive. So, this drug, if you're worried about your brain getting ischemic while you're intubating them, this drug is actually decreasing the amount of oxygen your brain is consuming by 35 to 40%. So that's pretty cool. It may activate seizure activity. So it does have the clonus type activity. And you can see here that even though you see it has the clonus activity, it may suppress seizure activity. But it can augment the amplitude of SSEPs, which are peripheral electrical signals. So it's kind of a complicated neurological drug. That's why I call it a dirty drug, because it's not a real clean profile drug. If you extravasate this drug, if your IV blows when you're giving this drug, or if you're just giving this drug, it's going to burn like hell if they're awake. People do not like this drug going in their IV. So if you can give them some lidocaine in their IV right before you give it, do that. They'll like you for that. But if you can't, then run your IV really fast when you're giving it. So besides that, onset's really fast with this drug, 30 to 60 seconds. But it also wears off really quick. It's got a large redistribution. So they're going to wake up pretty quick from this drug. Oh, and they normally, like 50% of them puke after getting Etomidate. Yeah. Vomitate is the other name. That's what we call it. Vomitate. So, dirty drug. But it'll knock them out real quick to intubate them. It really will. And it'll normally maintain their blood pressure unless they're already CV compromised. So, any questions about it? Look there. Rapid awakening. So, you know, the barbiturates we used to always give, people would wake up lethargic. You know, they'd wake up drunk. With Etomidate, they just wake up and puke. So, if they wake up really fast, what do you think you're going to have to give them after you tube them? Versed, fentanyl, something. You can't just put a tube in them and expect them to be happy about it. Because this stuff is not going to hang around. And the succinylcholine is going to be gone. And is their gag reflex going to come back? Yeah. They're going to wake up bucking like, you know, a bull down in Silver Valley. They'll be pissed. So they will often get the myoclonus. You can pre-med with some Versed or an opioid to try and prevent that. It's pretty impressive though. They'll look like they're going to have a seizure sometimes after you give this stuff. And about half of them, like I said, will just buck down after you give it. And the other half of them will relax. So, dirty drug. Ketamine. PCP. Legal PCP. Phenylcyclidine derivative. This stuff makes you see crazy stuff. Don't give this drug without giving Versed. Don't do it. I'm serious. That's not a joke. Because they will wake up and 30 years from now, they'll be talking about the nightmares they have. This drug causes the worst nightmares ever. Realistic nightmares. And they think it's real. I'm not making this up. It's proven. So if you give ketamine, you need to give them at least 2 milligrams of Versed before or after. At least 2 milligrams, preferably 4. I'm serious. That is not a joke. This drug is rapidly uptaken IM. So we talked about, you know, your IV blowing or something. But if you need a calm me down drug, this probably isn't in your protocol. But if you have somebody going ape shit, this is your drug. This is what we use to get the, how can I put this politically correct? The unstable ones that aren't all there into the facility. We will go out to their vehicles and ketamine dart them. We'll jump on them in their vehicle and go right through their clothes with a ketamine IM injection, and within 5 minutes they're looking at you and they've got the nystagmus, their eyes are twitching, they're drooling a little bit. So you'll run the risk of a laryngospasm because this causes heavy secretions. It almost causes a cholinergic type reaction. So you can give a we call it, it's anticholinergic, but there's another term we use for it, antilingual, which decreases the secretions at the same time. Like you can mix a little Robenal or glycopyrrolate, something similar to atropine, in with the ketamine to prevent that. But of course, that'll cause the tachycardia. But if you do that, you can saw their arm off and they won't know it. They're looking right at you, and you can operate on them. We've done ketamine surgeries before, and it's the craziest thing. They're looking right at you while the surgeon's cutting into them. I'm like, this is so freaky. You're freaking me out. And I'm just sitting there bumping them with 20 milligrams of ketamine every couple of minutes, and they're just sitting there, eyes are twitching, and I'm like, it's so crazy. You're cutting on them, and they're just looking at me. So it's a completely dissociative anesthetic is what it's called, because it disassociates their reticular activating center from the rest of their cortex in their body. So you've locked out their brain from their consciousness. So they're in there, the lights are on, but nobody's home. It can cause some paradoxical myocardial depression. However, it can cause catecholamine release, so you usually get an increase in the heart rate and an increase in your cardiac output. And because of this, use with caution in patients with coronary artery disease because of the tachycardia and the catecholamine depletion. Post-anesthetic emergence reactions and delirium occur in 12% of the patients because of the nightmares. Give them the Versed. Drug of choice for active bronchospasms. So this can cause laryngospasms because of the secretions. But if you got somebody who's having bronchospasms, status asthmaticus, ketamine will break a bronchospasm. It will absolutely break a bronchospasm. So let's see, what else can we tell you about ketamine? It is pretty lipid soluble, and it will actually work for a good 45 minutes when you give it to them without redosing it. So you give them a pretty hefty dose of ketamine, and you're going to get a pretty good response for a while. But when you see their eyes stop twitching, nystagmus is gone, it's about time to redose it. Any questions on this dissociative anesthetic? All right, succinylcholine. So acetylcholine is the primary neurotransmitter in your body. Succinylcholine is nothing but two acetylcholine molecules bound together, and you inject it in their body to muck everything up. So what succinylcholine does is it rushes in and binds all of your little subunits open at your neuromuscular junction. And what that does is that allows all these neurotransmitters to rush out and all these electrolytes to come out and all these muscles to contract at the same time. And once they contract, they can't reset because everything's bound open. Normally when something contracts, it resets. Are y'all familiar with the whole depolarization, repolarization cycle and all that stuff? I'm not going to get into all that, but you know, you have an electrical impulse, it fires, then it resets. Well, this makes it fire and keeps it open in the fired position, and it can't reset. So you contract, you fasciculate, and you can't reset. So you relax. This is called a depolarizing muscle relaxant because you depolarize that neuromuscular junction. So this is great. It's the fastest acting neuromuscular blocker that we have. It's one of the oldest ones. It's one of the most reliable ones. It's not necessarily the safest ones because when we bind those little junctions open, you allow the potassium to rush out into the extracellular compartment where it doesn't belong. When that occurs, your blood potassium level shoots up and you run the risk of causing the heart to stop. That's normally not a problem in normal healthy patients, but if you have a burn patient who's a couple days out from a burn, or if you have a patient who's been bedridden, who has developed all these extra junctional receptors, because when you're laying in the bed and your body's not getting stimulated, your body thinks it needs to be stimulated. So it starts developing all these new nerve receptors because it's pissed off because it's not getting stimulated. Everybody wants to be stimulated, right? So it starts getting all these extra receptors. Well, now that you have twice as many receptors, you have twice as many openings for the potassium to leak out. So the succinylcholine comes in, opens these areas. Now you have twice as much potassium coming out into grandma's blood. It goes to her heart and it arrests her heart. Now her heart stopped and it's your fault. You did it. So you have to be wary of this if you have somebody who is bedridden and doesn't even move. You have to be cognizant of this with individuals who have muscular dystrophies, individuals with recent burns, individuals with crush injuries, because those crushed muscles are going to be releasing potassium. So those you have to look out for. People you're not going to know about have atypical plasma cholinesterase. These are individuals who are not going to metabolize this succinylcholinesterase. You have homozygotic and heterozygotic atypical plasma cholinesterase, and you'll never know about these people until the succinylcholine just doesn't wear off. And that'll be figured out hours later. So I wouldn't even think about that. Just give them the drug. But ultra short duration, it's only going to work for a couple minutes, but it gives you amazing paralysis. Everybody thinks when you give this drug, though, you're going to see this wonderful fasciculation, and it's going to be very prominent, and then they're just going to relax, and their mouth's going to fall open, and they're going to be like, put the tube in. It doesn't always look like that. Sometimes the fasciculations are going to be very small. Sometimes it just might be their cheek. And it might just be a second that it occurs.